Welcome back to our Cardiac Defect of the Week series. I'm Tim Rogers, one of the intensivists here at Kaiser, Oakland. This week we're going to be discussing coarctation of the aorta. Remember that coarctation of the aorta means a discrete narrowing of the descending aortic lumen at the level and the area of the ductus arteriosus. But it's a spectrum really, going from coarctation or narrowing to a completely interrupted aortic arch. All patients with severe coarctation of the aorta or interrupted aortic arch should undergo elective surgical repair within a week or two after being born. But if they are developing LV or left ventricular failure due to outflow obstruction, then more urgent and timely intervention may be needed. If these patients have ductal-dependent systemic blood flow, meaning the only blood that's getting to their body is going through the PDA, then they will be on a prostaglandin infusion prior to surgery. The surgery for this repair is performed via a left posterior lateral thoracotomy and requires a period of aortic clamping, but rarely is cardiopulmonary bypass required. The repair usually involves an end-to-end anastomosis or end-to-side anastomosis. Some cases require a prosthetic patch to replace the segment removed that contains the coarct. The postoperative care of this patient population can be divided into fluid management, sedation and analgesia, inotropic support, respiratory management, electrical cardiac care, and anticipated complications. In terms of fluid management, restriction is typically unnecessary after coarctation repair, unless cardiopulmonary bypass was used to repair other associated lesions. Pain control can be a challenge in this population because thoracotomies are potentially painful, yet we also want the patients breathing effectively. So we'll schedule Tylenol, and if there's no risk of bleeding, we'll do some scheduled Toradol as well. We also will do narcotics like fentanyl. In terms of respiratory management, patients are typically extubated in the OR or soon thereafter in the ICU. If there is immediate failure of extubation, suspicion for phrenic nerve injury, which is the nerve that innervates the diaphragm, or recurrent laryngeal nerve injury, which innervates the vocal cords, should be high. Inotropic support is seldom required. If so, low-dose dopamine at 3 to 5 mics per kilo per minute will be used. Tachycardia, in terms of anticipated complications, tachycardia and systemic hypertension may occur due to baroreceptor dysfunction after surgery in this patient population. Also, an increase in circulating catecholamines after surgery can make the tachycardia and hypertension worse. So medications like esmolol may be used to combat this as we try to avoid excessive hypertension, especially because the patients had a new anastomosis at the surgical site and bleeding could occur there. Another known complication is post-coarctectomy syndrome. This manifests as abdominal pain and tenderness with hypertension, fever, and high white blood cell count 2 to 3 days after repair. This is thought to be due to a sudden increase in mesenteric perfusion after surgery, being that the coarct has been repaired. Another known complication is chylothorax due to injury of the thoracic duct. Infants may need to be on a special medium-chain fatty acid formula to combat this after surgery. Injury to the left recurrent laryngeal nerve may also occur, and in this case you'll see stridor and respiratory distress immediately upon extubation, as well as feeding difficulties later on. Finally, spinal cord ischemia is a rare but serious complication of this surgery, so close attention must be paid to the neurologic exam in the days post-op.